Kapil is the co-founder and president of Beterra Health. Kapil, would you like to introduce our guests?
Thank you, Lila. Good afternoon, everyone, and thank you for your patience today and your time. We will use the next 35 to 40 minutes to have an open and honest conversation on the practical work of patient safety improvement. I have here with me two leaders who do this day in and day out. Let me take a few moments to introduce them and share their journey. The first one we have on the board as a panelist today is Jessica Bernhorst. Jessica comes from the Auctioner Health System. We all know they are a leader in safety and quality. Over the past few years, they have done systematic work in improving patient safety culture and have gained significant traction over the years. Jessica is the Systems Director of Quality and Patient Safety. She helps shape a lot of this work that happens at Auctioner. Some of their major system-wide initiatives include Chess Culture, RCA Squared, and so forth. The next panelist we have here today is Lori Colucci. She's from DeSoto Memorial. She's the Director of Nursing and Patient Safety Officer at DeSoto Memorial. DeSoto is a small community hospital in Arcadia, Florida. They have done some amazing work, such as unit-based quality boards, getting to the roots of the handoffs and transition problems, and so forth. The good part about all of this work is that they are in the 90th percentile of all US hospitals that submit data to AHRQ on patient safety culture. That means they are above 90% of the US hospitals in their performance. The specific reason Lori joins us today is to shed light into making improvement happen, especially at smaller hospitals with limited resources. But the common theme here, if you look, is that all of them has a systematic approach towards improvement. It encompasses thoughtful measurement, meaningful engagement, deep understanding, and focused action. But before we get into all of this, I want to make sure that we are all on the level playing field here with our assumptions. We assume that all the members who have joined here and their organization is already using a tool to measure safety culture. And we have a consistent rhythm of 24 months every 2 years or lesser. We also know that or believe that these organizations, including yours, have significant variability in creating engagement, having improvement, and results within your microcultures. And we also know that, assume and know that we all want more traction. So what are we really going to talk about today? You all provided a lot of good feedback on what we wanted to hear. So thank you for setting the agenda for today. We are going to talk really about the practical work of improvement. We will hear about how to measure and make the most out of patient safety culture data. We will hear from our panelists on their experience in engaging the organization to make meaningful impact and so forth. So without further ado, let's begin. One of the key questions we have as we think about this is how often do we measure? This is almost a very critical question, right? So let's hear from Lori and her team on how they made that decision. Lori, how often does your facility measure? And also elaborate a little bit more on how you found the right balance and rhythm towards it.
Well, hi, Kapil. Thank you very much for having me here today. Our measurement rhythm is really based on the data that we need to look at. And when we decided to do our safety culture survey data in the past, it was very difficult because actually measuring the data was done manually. It was very hard for us to do, especially as a small facility that does not have a lot of resources to reach out and to use. So as I said before, everything was done manually. So our measurement of data, we are doing annually with our safety culture survey. And we have been doing it now with Beterra for the last 2 years. And we find that by using your services, it has been so helpful to us. And we can see immediate results as well. So we do those, as I said, annually. And we're very steady. Once we finish a project or we look at something that we found in the data that's been provided to us, we move on to the next thing. And is it the right balance? It is for us. It is what we have to do to keep our staff informed on everything that we're doing to keep our patients safe.
Oh, that's great perspective. Jessica, how does it feel when you have more than 10 hospitals of different sizes? And how, as a system, do you find that rhythm? Jessica? I apologize. I think there are some technical difficulties still lingering. Jessica, are you
Can you
able
hear
to
me
hear?
okay?
Yes, great.
Okay. Sorry about that. So I think, as one of our biggest challenges is we have, such variation in size. We have, between our hospitals, we have one critical access hospital. We have one hospital that's close to 600 beds. It's an academic medical center. And we have several community hospitals that kind of are between those two. And so I think finding the right rhythm was really important for us. And we also do our survey on a yearly basis. And part of it is making sure that we're able to provide feedback. I know that AHRQ only does the reporting every other year, but we thought that wasn't enough turnaround or quick enough feedback for our different hospitals. And of course, we have different sort of initiatives going on at each of our hospitals because of their different size. And obviously the culture changes a lot between with the size of the hospital.
Absolutely. I think that's a very important. I think both of you just mentioned a very important point. You have to find what really works for you and your facility, and how often you are going to take action. It's really about creating your improvement cycle. So let me ask you a bit more about the engagement aspect towards asking for feedback every year, and doing that improvement work every year. We know it's very difficult to engage any team, whether it be a team of leaders or whether it be frontline staff. And if you look at the data as a group that we had here, uh, almost 60% says that we have executive engagement, and then the rest is somewhat or unsure. If you want to really make any kind of improvement as a group here, we need to have 100% executive engagement. So Jessica, let me ask you this question: how do you create engagement among your systems level leaders as well as facility level leaders?
One of the primary ways that we actually sort of start the engagement of our survey is we have a system quality group. So once a month we get together for half a day. It's all of our chief nursing officers, all of our vice president of medical affairs, our quality directors, pharmacy directors, lab directors, et cetera. And we meet once a month for half a day and talk about different quality and patient safety topics that come up. And so because this is one of our primary tools for measuring kind of our ongoing safety, or a big outcome measure for us, this is sort of where we start talking about it. And we've been very successful over the last few years also, because a lot of our team members in that group also sit on the executive teams of their individual facilities and our system level governance. It really helps kind of bring the conversation to a different level. And so we've really been able to engage that group. We show them the results. We talk about the survey, what's going on with the survey, and what the action plans are as a result of the survey in that group. And again, that really helps drive the engagement at the senior level of all of our facilities.
So are you saying that the action afterwards that happens from the surveys that has helped creating that consistent engagement among leaders?
Yes, I think if we don't share what happens continually with the survey, when we don't do that, we see the results on the survey. I mean, I think, we have to actively talk about the survey, what everyone is doing about the survey, not just present the survey results and kind of forget about it for another 9 months.
Oh, that's a great point. Let me also ask you one other question on this aspect. How do you fit in physicians in this picture?
So our physicians, again, they're part of this quality group, but one of the things that we do is when we do our surveys, we have a portal that we have for each of our facilities, but we also have a separate portal for our physicians. And of course, as we try to increase the number of physicians that take the survey, we have to engage them a little bit differently. We actually use our electronic learning system to distribute our survey to all of the staff, but are really a little bit more personal in the way that we engage the physicians to take the survey. They're not always great at getting into the electronic learning system. So for them, having our medical leaders, our physician leaders reach out to them either via email or talking to them about it at physician meetings is a really important way to start engaging the physicians. And so one of the things that we're able to do, because we create this separate portal for the physicians, that we can always map it back into our facility results, so it does become part of our overall facility, but we can look at we can measure their results separately. And so that provides a lot of really meaningful use to them. There's no sort of being able to push or use the excuse that this doesn't include physicians, or sort of physicians are outweighed by other types of staff members like nurses or whatever. We have specific physician data.
I think that's very important to really understand. Still, our unit-based culture treats physicians as the leaders of clinical groups. So the engaging physicians and having that success is critical. Lori, is that similar in a smaller facility like yours? Do you have similar physician silos that most of the larger organizations face, or is your context different?
Well, Capel, I agree with Jessica in a lot of ways. I also believe that now for hospitals to be successful in patient safety, that you have to engage the entire team, which includes the physicians. We have found that since we do have some, people that are not as technologically savvy in our physician group, because we do have some older physician grouping, we have found that we can reach out and assist them, and that is going to be one of our major focuses in the upcoming surveys. But I do find that it is very important to do that, because they have to be a part of that team for us to meet the patient safety measures and to provide the safe, quality patient care that we need for best practices. So it's absolutely imperative that they do engage. We do have a couple silos, but we're working on them as well.
That's great. I think engagement, measurement, all of this is really important in order to garner feedback and to act. But how do we really create a clear understanding across the organizations? I would like to get input from both of you, because as it becomes such an integral part to the success of the work we are trying to do. Let's dive a little bit more into that. How does your organization process this information, Lori? I mean, you are a small hospital in Arcadia, Florida. You have limited resources. And you have a lot of quality improvement projects going on at the same time to be at the top tier of quality and safety, and which you are doing wonderfully. So how does your organization process this information?
Well, the way that we process it is by engaging everyone. And, that's something that's much easier in a small facility. We don't, as I said, have the resources, but we do. We work from the top. So we start by engaging our leadership, and we do that by having them at every meeting. Our entire teams are set up of our quality, our pharmacy, our patient safety. Everyone is involved and we can't forget the staff members too. They're involved as well. And we have many different ways that we present the information, because you want to present it so that it's meaningful for every tier. And that goes from leadership down to the patient care areas, and down to your ancillary staff as well, because they're all a part of our patient safety. So we do that by making sure that they receive the reports. We run all of these reports, we share it with leadership, and then we also have patient safety boards that we put up for our staff, so that just about anybody can observe how we're doing according to patient safety.
Explain a little bit about that patient safety board, if you don't mind, Lori.
Sure. We have quality boards in each one of our departments, and we put up information for our staff on those. The patient safety board is a small, well, actually it's a poster size that we put up that includes information on things such as falls and and CAUTI and CLABSI, all the different things that our patients that has to do with patient safety. And this is observable by anyone that wants to look at the board. We also go about explaining it to them as well. And we reference that to our patient safety surveys, because our patient safety surveys really drive those patient boards.
That's really very, very important point. So that's how you are connecting other safety and quality related metrics to patient safety culture, and being able to do that real time to ensure that you create a common schematic of an understanding across your organization. Jessica, if you don't mind, can you explain some of the challenges and barriers you have encountered towards creating this understanding, and how you went about that throughout your journey? Because your facility, your organization is very methodical about this work. How have you done that?
Yeah, so actually, I think that's it's been one of our biggest challenges is not only, making a drive to, have improvement around patient safety, but being able to connect the dots for our staff. And we see that year after year with our staff, and we also see it actually in the difference in our scores between our leaders and our frontline staff, is that we have all of these initiatives that we're doing for patient safety, but we're not always connecting the dots for staff and speaking about it like it is referring to patient safety. We think about regulatory readiness the same way. Regulatory readiness is for patient safety, but we don't always connect the dots for folks. So we've done a lot of work, and I think a lot of it has really been communications. We're really fortunate, and we have a very robust internal communications team, and they've really helped us learn how to message things for the staff. And I think also being very transparent with the data. I agree with Lori. Part of the first step in making sure that our staff understands the data is getting the data to them, making sure that they're able to ask questions about the survey. And again, really truly understanding the data, but again, making the connections between the improvements that we're making, whether it's investments that we're making, physical investments for safety, or, initiatives that we have around patient safety. Thinking about one of the big initiatives we had is the Just Culture. One of the big successes of our Just Culture system is that we have communicated it to patients or to our staff as this is a patient safety tool. This is a tool for you to speak out about patient safety and to not be fearful about it. And so again, really connecting those dots for folks, and communication is really key, and the way that you communicate it out to the staff, again, something that we continue to work on. What's the best way to share with staff as we put out new initiatives, again, making those connections to them, that this improvement initiative is not just for a financial gain, or if it's not to make operations quicker, it really is to improve the safety of our patients.
Jessica, just to push you a little bit more on that, how effective does that rollout happen from the systems level as you set the momentum to do that to the facility level? Because you auctioneer cuts across a vast geographical area. How do you make sure that you have the same kind of understanding from your corporate offices to your clinics in the Bayou region to your facilities in Kenner? How do you do that? How have you done that so successfully so far?
We really rely on our teams, on our quality teams, and our nursing teams, and our leadership teams at each of the individual facilities. We can provide them all of the resources and all of the data and cascade it down to those teams, but we really rely on those teams to connect with their staff, to create individual action plans within their facility so that they can share that data with not only their leaders, but also their staff. So a lot of it is, again, really creating that engagement of those key leaders at the system level, and helping them with whatever resources they need and whatever information they need, so that they can continue to cascade that down to their individual facilities.
That's a great point. I think you are now talking about engagement, understanding, and alignment to create an infrastructure towards sharing the results and then creating the accountability towards acting. Let's actually talk a little bit more about that. Do you have any best practices you can share? Lori, why don't you take a shot at that question? Do you have any best practices around how you have created alignment within your different department level leaders and your senior executives as you have done this journey? Lori, are you still there?
Oh, I'm sorry, Capel, could you repeat that? I only caught part of that.
Sure, sure. I think what Jessica was really mentioning was about creating the alignment towards, creating that understanding, creating the alignment towards having a functional leadership team cascade the message and the work from systems level to facility level leaders. I was just
Oh, yeah.
hoping to understand the similar kind of working that happens in your environment. You are not you are not really a system but a hospital, but still the cascading effect has to happen, right? The roll down has to happen from your executive team to your safety and quality team, and from that to your each individual departments and so forth, if you will. Do you have any best practices? Do you have any any kind of tips and tricks you want to actually share with this community?
Well, first and foremost, I think the thing that drives everything for us, especially with our executive committees, is the fact that patient safety is so important. I mean, we stress that to them and then they buy in. So when it comes to our executive committee, that's basically where it comes from. And it's not difficult to encourage help from your CEO or your CFO when they're a part of that patient safety team. So we include them in our team. And you know, our team structure is very important. We definitely want the buy-in of our quality director. She is wonderful. Our quality director is Tracy Winslow. She's very creative in the way that she shares information with the leadership teams and with the staff members and with our department directors. And we don't have as many large teams to have to work with. So it makes it's a direct team that we all work together, and it does, as Jessica said, it cascades down. But we also look at it as we're all on the same level playing field because it is patient safety and that is our priority. So it does work its way down, but we're all right there. Some of the initiatives specifically that we've used to do that, I've discussed the Patient Safety Board, but some of the other things that we've done as well are things such as our basically our initiative to improve our bedside reports, our transitions. That's one of the major initiatives that we saw that we were falling down on before. So we look to improve that by focusing in and using things such as our skills fair, sharing the information from the survey. We revamped our entire method of doing reports and patient care transitions, and that was a huge initiative for us. And we feel that the staff members that are participating in that feel that it's really working, but it is still something that we want to focus in on and work more on.
That's great, and it's really informative. I know it's a slight deviation from what we are talking about, but I believe that, and we have seen this handoffs and transitions are a big issue for a lot of our facilities. I know you have been working a lot on that. Do you want to specifically provide some of the insights around that? Take a couple of minutes to share that, even if I think it will be of worth value to this group to just hear about that a bit more.
Well, what we did with our transitions, basically our patient care transition, we found that we were having transporters take our patients to the units. And being a small facility, we decided that it would be better to do bedside nursing report. Our nurses travel with the patients to the units to give a bedside report to our patient. We improved some of the methods that we used to transfer patients to different units when they're having testing done. They go with a hall pass, so we've improved our communication there. But really our main focus was the bedside transition, the patient care transition at the bedside, going unit to unit. And we really focused in on changing the actual report itself so that all of the highlights are hit and that it's done nurse to nurse, specifically at the patient's bedside. We find that when the patient's involved in the team, it works much better, and everybody is aware of what's going on. So that was one of our big issues with our patient safety. We felt that's where we were falling down. So that's one of the main focuses that we chose to improve upon between our last survey and our current survey.
Thanks, Lori, for sharing that extra tip here. I think one of the key things we all know that in order to really enable action, we need alignment. We talked about that a bit here already, but we also need the infrastructure and the accountability to do that. Um, Jessica, do you mind explaining the team structures that you use for your improvement initiatives, and especially around safety culture? You already mentioned that you rely a lot on your facility level leaders, but how does that team structure look like from the systems level to facility levels? How does that model transition for you?
So we kind of consider our sort of quality leaders at each of our facilities. Again, these are the folks that are included in our system meetings. We have the VPMA, our Vice President of Medical Affairs, our quality director, and our nursing director. That kind of triad works really closely together as we work on patient safety initiatives. So they really, at the facility level, they're the ones who are really helping drive those initiatives and, building accountability. And again, those folks are also part of our executive teams. Certainly our CNOs and our VPMAs are part of each of the facility executive teams. So again, they can help build that accountability at the facility level. And we bring all those folks together at the system level to kind of to share and to strategize and to help educate those folks and give them the support that they need for each of for the work that they do at their facilities. So we can kind of set the system strategy with that team, and they can bring it down to each of their facilities.
And does the facility level team, do they have a similar structure for each of the units, or do they have a different type of structure?
It's very similar across each of our facilities. So again, our quality infrastructure at each of the facilities is very similar. We have a performance improvement, we call them PI, our PI director at each of our facilities. And then we have several coordinators that work under them. There's a little bit of different structure from facility to facility. Some of them cover infection control and patient relations and education and sort of some variety of that, but usually those are sort of the areas that fall under them. But there's also a core group of performance improvement coordinators that do a lot of sort of the legwork, that work under that PI coordinator, and they're really the ones that are out there working with the staff, sharing the data, and kind of answering questions for the staff as well. But a similar, obviously a little bit of variation between each of our facilities, but it's a similar structure.
Okay, great. Lori, I think you also mentioned that you have your CEOs and the CNOs and the CFOs as part of the team as you do your improvement work. How does that work on a day-to-day basis with the competing priorities you have?
Well, it can be difficult because we do, many of us wear more than one hat, I will say. However, we do have daily meetings. We have a morning huddle where all of our department directors come in. So our leadership is available to us at all times. We do have leadership meetings every Tuesday. Patient safety is one of the main conversations at our leadership meetings. And we do reflect on this survey, and our staff had been looking forward to this survey from the beginning. So, and in our leadership meetings, it is the CFO, the CEO, Director of Nursing, Quality, Patient Safety, Risk, all of those are in our leadership, our direct leadership meetings. And being small, we do have these meetings more frequently. And it is difficult with our daily work, but we do find that it is so important that we need to add it in and work on these initiatives together.
That's good and enlightening to hear. I think one of the primary challenges, or the quintessential challenge, if you will, is to be able to create the focus and also set targets on those focus areas. How, as a system, do you create focus and set specific targets, Jessica?
I think for the targets, we set them at the system level. But one of the things, we have, again, in looking at our patient safety results, we look at them as an overall system. But then there's, again, very different culture in each of our facilities. So we don't sort of set one particular, we do set an overall target, but we have different targets for each of our facilities because they're all on a different step in that journey to patient safety and high reliability. So I think the initiatives and the targets that we set for each facility and the areas that we focus in are different for each facility. What we ask them is to really dig into their data and find out what are those pain points that they need to work on, and also to look at the areas that they've done really well on, and to do some fact finding around why those areas are also performing really well, and what can we learn from the areas that are doing well to support the areas that are not doing as well.
So you really create an infrastructure of best practice sharing within your facility, since you have such varied groups.
Yes, that's the big focus for us, is really sharing, again, creating accountability at the system level, but a lot of really sharing best practices across each of our facilities. We have, again, such a variety in cultures. We're geographically different, or different in sizes and a little bit in each of our structures. And so we really have a good pool of facilities of other organizations that we can learn within our own system. So, getting those groups together and being able to share, along with helping them set those targets and setting them, getting them to create alignment, I think is really, really important. And that's kind of what we want to do at the system level, is again, create that atmosphere where we can share and be transparent and learn from each other.
Absolutely. I think one of the core challenges, again, another aspect when it comes to the work itself, is ensuring that we engage our mid-level leaders and provide them the right kind of tools to do the improvement work, right? Because they have so many competing challenges on a day-to-day basis. So what kind of tools do you provide for your mid-level leaders to be able to do this work, other than just the safety culture results or a set of action plans? What kind of toolkits do you provide? Lori, do you want to take a pass at that question first?
Well, yes, Kapil. Basically, what we use at our facility is the tool that you've provided for us. I think that our patient safety survey really helps us to keep a focus on what we need to address. And the reason I feel that is because it is a direct response from our staff members.
Mm-hmm.
Our staff members have completed this in an honest way, because of course it is anonymous, so we know that they're going to be honest. And it's really a barometer of what the condition of your facility is. So therefore we use this, our survey as our tool for ourselves and for our managers. We also keep an open door policy so that our managers can come back and forth and share information with us and to reach out to us. And that's very important to them and to the staff. And once everyone is aware of what is going on between everyone, then they can work towards satisfying these issues and resolving these issues that we discovered by using the patient safety survey.
Absolutely. Jessica, are there any other toolkits that you are providing your mid-level managers and leaders at the facility level and your clinics towards improvement?
Yes. So, I agree with Lori. I think the most powerful tool that we have is the data and the comments for our staff, and to be able to get that information down to the frontline staff level is really, really powerful. We do provide some more sort of standardized report out tools for our team to use, and we're also starting to use the AHRQ action planning guide. We always provide some action planning templates for our facility level folks, so for kind of our senior level. But we're starting to use those HRQ templates for our sort of mid-level management, so they can look at their own area, and it's a tool that kind of makes them think a little bit more about their results and really analyze the results, and to be able to, it already has, again, our folks love templates. It gives them a tool to ask them what they need to provide, and so we found that really helpful, and we're rolling that out in many of our facilities this year.
Okay, great. I think we just received a question from one of the groups listening here. What is the time from your measurement to action as you give these tools, as we provide towards action, what's your time frame from measurement to action? Jessica and Lori, do you want to give a pass at that? We talked about creating the infrastructure. We talked about creating the understanding and all of that. But how the timeline? One of the members who is listening to this conference is curious about the timeline.
So this is Jessica. So one of the things that we do, so we usually do our survey in the month of March, and in the beginning of May, we start sharing all of those results at the system level and at the facility level. And as we start sharing those results, we start talking a little bit about action and, really analyzing the data. And typically by the middle of the summer, towards the end of the summer, is when we're asking folks to come back with action plans so that they have enough time to really start doing those actions and start doing a little bit of initial measurement on some process metrics before we hit that next survey date the following March.
So you see, so you're really saying your improvement cycle is every 12 months from measurement to action and then to the next measurement. How
Yes.
about you, Lori? I think it seems very similar, right?
Yes, it is very similar, Kapil. It also depends on the initiative itself that we're working on as to how long it would take. But I have to agree, almost everything is on an annual cycle.
Annual cycle, and I believe that creates the rhythm, and that also creates the focus, and then the activation energy to do all of these things within a very specific time frame. That's great. I think we covered from a time standpoint. We are about 40 minutes now, and we covered some of the pressing topics here. Let me ask you, Jessica and Lori, both. Jessica, you might want to go first here. What would be one advice you would give for this community as they are in the trenches, or as they are living this day in and day out? What would be one advice you would give for this community to really improve patient safety culture and be able to sustain it?
I think one of the key learnings we've had is really trying to push information down to the frontline staff. So engaging the frontline staff in this, we're working on initiatives, and I say especially at the system level. Sometimes we sort of spread the message to those most immediate around us and then sort of let the message go. And so I think to get that information out to the frontline staff, and I think another really important learning for us has been over the last few years, we've seen improvement in our survey. We've gone down in some areas. And so I think to not kind of let your foot off the gas. So if you're doing well one year, that doesn't mean that you can take a break. I think that's been a big learning for us, is that you always have to keep pushing the staff and pushing those initiatives and, pushing those things that you've put in place, making sure that, so for us, if we did a lot of work around just culture, making sure that we're keeping up with that, because we can't let that go one year, or, staff that comes in or the staff that's there, they'll feel the change, and you'll see that change in your survey results as well as in just your culture.
Absolutely. Lori, what would you say?
I really agree with Jessica. That was great. I like what you said. Keep your foot on the gas. It's so important to keep your staff motivated, and sometimes it may be difficult, but to keep yourself motivated as well, because as you said before, it does trickle down. Also, I want to talk about keeping an open line of communication. I think communication is key, as well as transparency and sharing everything that you're finding, making sure that the staff know that the information that they're giving you is being put to use, and that you are interested in what they have to say about keeping our patients safe. I also think that it's imperative to use the tools that are provided. So this is a great tool that we've had given to us. I mean, it's wonderful to use, and to tailor your information to your use. I mean, you can see the difference between the facility that Jessica is running as compared to our little facility that I work for. So it is definitely important to tailor that information and use what works for you.
That both of you, those were great response, and thank you for sharing that wisdom. I think we have got a couple of more questions here from our audience. The first question is, if you could get your senior leaders to do one thing they don't do today, what would it be? Lori, do you want to take a pass at that question? The question again is,
Yeah,
if you could get your senior leaders to do one thing they don't do today, what would it be?
that's difficult because our senior leadership is, we're so small that, and it's such a small community. Um, it's very difficult to say something that they're not attempting to do because they do, I think communication is key. So maybe to be better at sharing decision making, I think that would probably be it. Because sometimes we feel like we're transparent because we feel like we're sharing information, but it may not get all the way down the line. So maybe that's it, to be better at sharing information.
Jessica, what do you think? Do you feel the same way, or do you have a different
Yes, I
take
would
on
say
that?
though, I think especially for our larger facilities, I think the higher up our leaders are, the kind of broader view you have of the data. And one thing I think is really important, and I wish more of our leaders did, is really dig down into the data and look at the unit levels, look at the kind of comments by unit levels, and kind of go out and connect with the staff on that unit. And so, not that everyone doesn't do that, but I think more focus on the culture at the individual unit would be fantastic.
That makes real sense, because those communication silos are what creates the perspective gaps, and leaders being on one side of the equation thinking that we have a great culture, and when the front line feels completely differently. And we have seen this throughout. It's a standard theme that we see everywhere. So there was one other very tactical question from one of our audience. The question is, I think there are two parts to the question. The first part is, what are your average response rate with an annual survey? And the associated part to that is, how do you increase and maintain your response rates? I think this is going to be this is a really good question, because, and you both have a lot to add here, Jessica and Laurie. You guys have always had consistent, since we know that you have consistently be above the benchmark on national average in terms of survey response rates, both in like 70 to 80%. How do you do that? That's a very important practical question. How do you do that?
This is Jessica, and I'll take a first stab at it. And I think with our big system, one of our key tools has been using our electronic learning system. So it's a system we used to use, HealthStream, and we use a similar system where you can assign online modules to, and that's really been a big tool that we've used. In the past, we used to use a paper survey, or also just tried distributing the website to folks, but really putting that out as an assignment. And again, it links out to the survey portal, so it's still anonymous. And that's something we always have to reemphasize with folks, because the LMS comes to them with their name assignment. But the LMS has really helped us be able to reach everybody. It automatically creates reminders, and that's really helped keep our survey results. Even at, we have close to 17,000 employees, and to be able to maintain that, above 70 percentile response rate.
Great. Laurie, do you have any special advice here?
Well, yes, from the small facility perspective, we actually do something similar. We use your link directly, so it is completely anonymous. I thought about using our LMS, but some of our employees had the same issue that Jessica spoke of. They were concerned that it wasn't anonymous. So we went ahead and just used the link, made sure that everyone had the link. Being small, it makes it a little bit easier to motivate people. So we would actually have, go around with candy or something, have you done your survey, and chat with people and discuss the importance of it specifically, which is difficult to do in a large facility. And and then just continuously tell people where we are. It almost, people are very competitive, and it almost made it a competitive environment, because I told them, well, we were here last year and our goal is here. Can we beat it? So just by their competitive nature, it made people, they would say to each other, have you done it yet? Have you done your survey yet? Even though, it's anonymous and nobody could tell if they specifically did it, they did feel that investment and that competitiveness about, completing the survey.
That's
I 100% agree with Lori. They are very competitive. Actually, our facilities, we provide weekly counts for them on where they are and their survey completion. And our PI teams do a lot of really great work in trying to get folks to take their survey. So a little bit of competition always helps.
That's great. I think we as a community need to have a little bit of competition around patient safety culture and the results, because if you look at the ground reality of us as a nation, we are not doing really very well in this measure. AHRQ says our average rate of improvement for every 24 months is 1% point, and if you look at it as at the absolute number level, only about 65% of our staff feel safe in the kind of environment where they are doing care as a community in this country. So I think, thank you, Jessica and Lori, for your time today and sharing your perspectives. I'm going to hand over this to Lila as we close today's webinar. She has some next steps as well as some of the next events we have.